In the second video of seronegative spondyloarthropathies, the first disease which we are going to discuss is psoriatic arthritis. Psoriatic arthritis is arthritis associated with psoriasis, but not all psoriasis patients will have a psoriatic arthritis. Only about 40% patient of psoriasis cause psoriatic arthritis. The psoriasis and the psoriatic arthritis are usually separated by many years. The average age of separation is about 10 to 15 years, mean that patient of psoriasis will develop psoriatic arthritis after 10 to 15 years. It usually occurs in younger population. What is the pathophysiology of a psoriatic arthritis? Psoriatic arthritis is a chronic autoimmune disease which occurs in a genetically susceptible individual. When these genetically susceptible individuals mean people who are HLA-B and HLA-C positive, predominantly HLA-B27 positive. When these people are exposed to environmental trigger such as infection, this will lead to immune activation. The immune activation predominantly involves dendritic cell and T cell. The T cell which is most commonly involved in psoriatic arthritis is CD8 positive T cell. Remember that this activation will lead to production of cytokines which will eventually cause psoriasis. The most common pathway which lead to psoriasis is interleukin 23 and 17 pathway. How this pathway occur? The dendritic cell will produce interleukin 23. This interleukin 23 will act on Th17 cell to produce a pro-inflammatory cytokine interleukin 17A. This interleukin 17A along with interferon gamma and the TNF alpha produced by Th1 helper cell will act on resident macrophage at joint spaces. Along with these cytokine which will act on a macrophage at the joint, and this will cause production of a more cytokine and lead to inflammation at joint, leading to widespread tissue damage. Now come toward the clinical feature of psoriatic arthritis. The psoriatic arthritis patient present with pain and stiffness involving joint, tendon, ligament and enthesis. Enthesis is the insertion site of a tendon and ligament. Remember that the joint involved in psoriatic arthritis have multiple patterns. Predominantly there are 5 patterns in which the arthritis can present. The first one is asymmetrical inflammatory monooligoarthritis. It is the most common type. About 40% cases of psoriatic arthritis present with asymmetrical monoarthritis. Second one is a symmetrical seronegative polyarthritis. This type, the symmetrical seronegative polyarthritis, occur in about 25% of a patient, and it is most oftenly confused with rheumatoid arthritis. So it is differentiated from the rheumatoid arthritis by absence of rheumatoid nodule, and it involves a DIP joint. The DIP joint is spared in rheumatoid arthritis. Apart from that, in psoriatic arthritis there will be a nail changes which is usually absent in rheumatoid arthritis. So these 3 factors, absence of rheumatoid nodule, involvement of a DIP joint and nail changes, differentiate this type from rheumatoid arthritis. The third one is the psoriatic spondylitis. This type present with inflammatory back pain or neck pain. It resembles this clinical feature of ankylosing spondylitis, but it is less severe. The fourth one is the predominantly DIP joint arthritis. In this type, the DIP joint is predominantly involved. The other disease in which a DIP joint is involved is osteoarthritis. So people often confuse this type of psoriatic arthritis with osteoarthritis. So this is usually differentiated by nail changes. There will be a nail changes in psoriatic arthritis. The fifth one is arthritis mutilans. It is the most severe form of psoriatic arthritis. It occurs in about 5% of a patient, and there will be a hand deformity. The hand deformity include a widespread destruction of the interphalanges which lead to a shortening of digit. Apart from arthritis, the psoriatic arthritis can cause enthesitis, which is the inflammation of the enthesis. It is actually an inflammation at the insertion site of a tendon and ligament. It predominantly affects Achilles tendon, leading to heel pain. Apart from enthesitis, it can also cause dactylitis. Dactylitis is the inflammation of finger and toes, which lead to a widespread inflammation of a soft tissue. As a result, the finger will attain a sausage shape. Apart from these changes, there is also a nail changes in psoriatic arthritis. The nail changes are the characteristic for psoriasis and psoriatic arthritis, and on the basis of these changes, we usually diagnose this condition. The nail changes which occur is thickening of a nail. The nail get thickened. The second one is nail pitting. The nail pitting means that there will be a small rounded depression and notches on skin. The third one is the oncolysis. The oncolysis means that there will be separation of nail from its nail bed. The fourth one is subungual hyperkeratosis. In a subungual hyperkeratosis, there is a deposition of a chalky substance under nail. Remember that this occurs because when the nail gets separated from its nail bed, there will be a development of an infection which lead to subungual hyperkeratosis. Now come toward the diagnosis of psoriatic arthritis. The diagnosis is usually a clinical diagnosis. We diagnose the psoriatic arthritis clinically. There is a scoring criteria for diagnosis psoriatic arthritis clinically. This is called as a Caspar criteria. The Caspar criteria include current psoriasis, history of a psoriasis in first and second degree relative, psoriatic nail dystrophy, negative IgM rheumatoid factor, current dactylitis, history of dactylitis, and the juxta articular new bone. But remember that the juxta articular new bone formation should be something other than osteophyte. So all of these variables contain 1 point except the current psoriasis which contain 2 point. If the score get higher than 3, we say that the patient have a psoriatic arthritis. Apart from Caspar criteria, there are some laboratory and radiological tests which can be performed for diagnosis of a psoriatic arthritis. It include CBC, CRP, rheumatoid antigen and ANF. Remember that the CBC will show high ESR and the CRP will also be raised, but this is usually raised in active disease. The rheumatoid antigen and the ANF will be negative. The radiological finding in psoriatic arthritis predominantly occur in X-ray hand and X-ray sacroiliac joint. In X-ray hand, there will be the destruction of the DIP joint with deformity. Along with that, there will be a punch-out lesion and pencil in cup appearance. In pencil cup appearance, the narrow distal end of the proximal bone fit into the splayed out proximal end of the distal bone. So this will look like that pencil is fitting into a cup, so it is called as a pencil cup appearance, and it is usually a characteristic for psoriatic arthritis. Apart from pencil in cup appearance, the hand also show an opera glass appearance. So what happened in opera glass appearance? As a result of the long-standing psoriatic arthritis, there will be destruction of interphalanges. Due to destruction of the interphalanges, the neighboring digits will enter into one another and the skin will fold around it. So it will give an appearance of a telescope called as a opera glass hand. You can see the opera glass hand in this image produced due to a long-standing psoriatic arthritis. In the X-ray of sacroiliac joint, there will be a joint space narrowing leading to a sacroiliitis. Now at last come toward the treatment of psoriatic arthritis. For mild symptom, we use NSAID. If the patient is not responding to NSAID, we replace the NSAID with DMARDs. The DMARDs which is most commonly used is methotrexate. Because along with the arthritis, the methotrexate is beneficial in treating the skin manifestation of psoriatic arthritis. Apart from methotrexate, we can also use sulfasalazine, cyclosporin and the leflunomide. But remember that the hydroxychloroquine is usually avoided in psoriatic arthritis because it can cause a skin exfoliation. If the patient is not responding to the DMARDs, we replace the DMARD with anti-TNF alpha inhibitor. If the patient is even not responding to anti-TNF alpha inhibitor, we switch to a monoclonal antibody therapy. The two monoclonal antibody used in the treatment of psoriatic arthritis is oskeolumab, which is a P40 subunit inhibitor of interleukin 12 and 23, and the seroconazumab is inhibitor of interleukin 17 alpha inhibitor. As I say in the pathogenesis that the interleukin 23 and the 17 pathway is involved in pathogenesis of psoriatic arthritis. So by inhibiting these two interleukin, we inhibit the disease progression of psoriatic arthritis. After psoriatic arthritis, the next disease which we are going to discuss is a reactive arthritis. Reactive arthritis is a type of a seronegative spondyloarthropathies in which arthritis is associated with infection. How arthritis is associated with infection? If a patient have a previous history of infection such as urethritis, diarrhea or dysentery caused by GI bacteria such as Shigella, Campylobacter, Yersinia and the urogenital bacteria Campylobacter. When a patient have an infection caused by these organisms present with arthritis, this is called as a reactive arthritis. Clinical manifestation of the reactive arthritis will be that the patient will have a symmetrical oligoarthritis involving bigger joints such as knee and ankle. Along with this, the patient can also have enthesitis and dactylitis. Apart from these articular manifestations, the patient can also have an extra articular manifestation such as conjunctivitis and urethritis. Apart from these conditions, the patient can also have a skin condition such as a keratoderma blennorrhagica. We diagnose the reactive arthritis clinically and we treat the patient by treating the underlying cause, mean that we will give antibiotic to treat the primary infection which will eventually treat the reactive arthritis. If the patient arthritis symptom still persist, we can use NSAID, glucocorticoids, and rarely we can use DMARDs. So it was all about the reactive arthritis. But remember that people often confuse reactive arthritis and the Reiter syndrome. So remember that the Reiter syndrome is a seronegative arthritis characterized by arthritis, conjunctivitis, and urethritis. When all the three clinical manifestations are present, we say patient have a Reiter syndrome. While the reactive arthritis mean that only arthritis occur after an attack of diarrhea, dysentery, and sexual exposure caused by Salmonella, Shigella, Campylobacter, and Chlamydia. So technically, the reactive arthritis is a variety of a Reiter syndrome, which only involve joint. After reactive arthritis, the next disease which we're gonna study is inflammatory bowel disease associated arthritis. The inflammatory bowel disease involves two diseases, Crohn's disease and ulcerative colitis. They frequently involve joint causing arthritis. There are two patterns. In type 1 pattern, there are less than 5 joints involved, and this type predominantly involve large joints such as knee, hip, and shoulder. And the symptom often flare with GI symptom. In the type 2 pattern, there are more than 5 joints involved, but this type predominantly involves small joint of hand, and this pattern is independent of GI disease. Other than arthritis, the inflammatory bowel disease also cause spondylitis and sacroiliitis, and they rarely cause enthesitis and dactylitis. The last type of seronegative spondyloarthropathies is called undifferentiated spondyloarthropathies. This term is used when a patient presents with a symptom of reactive arthritis, but the history of a previous infection is absent. So, in the absence of infection, when a patient presenting with a symptom of a reactive arthritis, this is called as undifferentiated spondyloarthropathy.